Welcome, everyone. My name is Kate Brocker, and I'm the Director of the Wellness Institute at the National Epilepsy Foundation. We are so thankful to Dr. Manderscheid and the National Association of County Behavioral Health and Development Disability Directors for hosting this educational webinar for us today, and are so pleased that you've joined us this afternoon. Today's webinar will focus on the social determinants of health and epilepsy. All participants will remain muted during the presentation, but we encourage you to type your questions in the chat box at any time. We'll do our best to address these questions at the end of today's webinar. Please try and keep all questions general in nature, as we cannot provide individual medical advice. At this time, I'd like to introduce you to our host and guest speaker for today's webinar. Dr. Ron Manderscheid serves as the Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. The association represents county and local authorities in Washington, D.C., and provides a national program of technical assistance and support. Concurrently, he is the Executive Director of the National Association for Rural Mental Health, Adjunct Professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, and Adjunct Professor, School of Social Work at University of Southern California. Dr. Manderscheid serves on the boards of the American Academy of Social Work and Social Welfare, the Employee Assistance Research Foundation, the Denya Institute, the Council on Quality and Leadership, and the National Registrar of Health Service Psychologists. He serves as the co-chair of the Coalition for the Whole Health. Previously, he served as director of the mental health and substance use programs at the global health sector of SRA International, and in several federal leadership roles at the U.S. Department of Health and Human Services. Throughout his career, he has emphasized and promoted peer and family concerns. He is a former member of the Secretary of Health and Human Services Advisory Committee on Healthy People 2020, past president on the Federal Executive Institute Alumni Association, past president of the FEIAA Foundation, past chairman of the American Public Health Mental Health Section, and a past member of the APHA Governing Council. He has also previously served as chairperson of Sociological Practice Section of the American Sociological Association, as president of the Washington Academy of Sciences and District of Columbia Sociological Society, and as president of ACMHA, the College for Behavioral Health Leadership. Recently, he co-edited a new text, Outcome Measurement in the Human Services, Cross-Cutting Issues and Methods in the Era of Health Reform, and contributed to a second new text, Public Mental Health. Previously, he served as a principal editor for 8 editions of Mental Health United States. He has also authored numerous scientific and professional publications on services to persons with mental illness and substance use conditions. He serves on several editorial boards and prepares a periodic blog for the behavioral health care executives. Also with us today is Dr. Magdalena Sawalski, who is a medical sociologist and health disparities researcher. Her research focuses on barriers to optimal health for vulnerable populations, including racial and ethnic minorities, low-income groups, and people living with chronic conditions. Her research has conducted and published studies examining immigrant mental health, social factors in epilepsy, and the role of religion and spirituality in HIV. Her work has been funded by the NIH, state agencies, and private organizations. She has also partnered with community and advocacy groups on community-engaged research projects. Her current projects examine healthcare provider views on medical cannabis and COVID-19 responses and outcomes in the United States of Poland. Dr. Sawalski teaches medical sociology, sociology of mental health, health disparities, healthcare systems, global health, and other sociology courses. Before I turn it over to my colleagues, I'd like to share with you all the mission of the Epilepsy Foundation, which is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. Today's webinar is made possible through our cooperative grant agreement with the Centers for Disease Control and Prevention. Thank you, Dr. Manderscheid and Dr. Sawalski, for providing today's learning, and at this time, I'll turn it over to my colleague.
So let me say just a couple words of introduction of why we are involved in this and why my organization is involved in this. So we've learned in the behavioral health field over the last, I would say, quarter century that a huge part of mental illness and also physical illnesses that ensue upon mental illness derive from trauma that people experience in their lives. And the trauma that people experience in their lives derives in large measure from the social and physical determinants of health that people are exposed to. So that has caused a refocus in our field to actually look at the role that specific social and determinants of health play in the creation of various types of mental illness and behavioral problems, including opioid use. And now, more recently, to also go just a hair farther upstream and say, how do the power dynamics of a community, power being power related to status, power related to money, and power related to political power in a community, actually play a role in racial disparities and inequities in those communities? And then how do they work their way through the system to cause an excess of behavioral illness in people who are minorities? So today we're going to look at this issue not with mental illness as a dependent variable, but rather as epilepsy as a dependent variable. So we're delighted to actually be partnering in this and to partner with the Epilepsy Foundation in this series of webinars. And I believe this is already number 7 in the series. So let me turn it over to my colleague, Dr. Saharsky, who will give us our talk today.
Good afternoon, and thank you so much for this introduction and for having me. I am honored to be here. I appreciate the invitation to come, and I appreciate all of you being here on this webinar. So the topic is the social determinants of health in epilepsy, but the first half of my talk will focus more generally on social determinants of health, and then we'll turn to a more careful look at social determinants of health in epilepsy. So the objectives for this webinar are to describe the social determinants of health framework, to define and distinguish health disparities and health inequities, to identify the social determinants of health and disparities in epilepsy, as well as strategies to address disparities in epilepsy. And finally, we will discuss the role of different stakeholders in epilepsy, including advocacy groups, healthcare systems, academic institutions, and community partnerships in eliminating disparities in epilepsy. Social determinants of health are defined as the conditions in which people are born, grow, live, work, and age. The framework for understanding social factors in health was developed by the World Health Organization Commission on the Social Determinants of Health. One of the leading members of the commission was Sir Michael Mermet, a British social epidemiologist, who in the 1980s published some of the groundbreaking research on how social position shapes the health of individuals, groups, and whole social classes. As the work accumulated with research from all over the world, the proposition that health is shaped by the distribution of money, power, and resources at all social levels has become an established fact. Since the distribution of power and resources is unequal, that is, social inequality is a norm to varying degrees in all societies, health inequalities are also pervasive. By now, the concept of health inequalities has advanced further. The global health community has reached the consensus that these socially produced health inequalities are largely unjust and avoidable. And the term health inequities has been adopted in the updated social determinants of health framework. So globally, we have entered a new stage where the goal is no longer just to describe health disparities, but develop and implement strategies to address health inequities through equity building. Sources of health disparities are many and include socioeconomic position, racial and ethnic background, age, gender, gender identity, sexual orientation, religion, and places where people live, whole neighborhoods, communities, and regions. I will review some of the most prominent of these factors. Next slide, please. The first and foremost source of social inequalities is social class. Could we go back one slide, please? Thank you. Each social class is characterized by specific socioeconomic status, often referred to as SES, based on income, educational opportunities, and occupational status. Research is clear that opportunities for optimal health increase with socioeconomic status. It is not only poverty, unemployment, food insecurity, or lack of housing that are associated with poor health, but there is a gradient in health. So chances for optimal health increase with each level in the socioeconomic hierarchy. Next slide, please. In addition to social class, individuals' position in society is defined by gender. Women experience a myriad of social disadvantages compared with men. Furthermore, gender identity has become an important source of health disparities. People who do not identify in binary terms are a vulnerable population that faces unique barriers to healthcare and optimal health. The national public health agencies have launched special programs in research and interventions to protect the health of sexual and gender minorities. Other social determinants of health include race and ethnicity. The racial ethnic disparities in COVID-19 and the Black Lives Matter movement have brought racial and ethnic inequalities to the forefront this year. Evidence, both scientific and anecdotal, is undeniable. There is racism in our society no matter how you slice it. Beyond individual experience, racism is rooted within our social institutions. For example, the justice system, education, healthcare, and so on. And so it is a structural problem. We don't really have time today to discuss this topic more in depth, but I believe that this is something that deserves a whole webinar on its own, for sure, to address structural racism. Next slide, please. So in addition to the factors I already listed in the right column on this slide are some additional factors, such as early childhood experiences and development, which shape each individual's life course, social support and community inclusivity, often referred to as a web of social capital factors, and other features of communities such as safety, availability of transportation, physical environment, and recreational and leisure opportunities. And so here's the comprehensive guiding framework on social factors in health, what they are and how they operate to influence health outcomes. Please think of it as a causal model, because it is a theory, right? In this model, the socioeconomic and political contextual factors on the left, from policy to culture and societal values, provide a backdrop for the social structure of the society, with the different classes and groups with varying levels of social power and resources. These are called the structural determinants of health. These factors in turn shape health outcomes through the so-called intermediary factors, which include material conditions, behavioral and biological factors, and psychosocial resources. There are also feedback effects that are hypothesized in this model. In particular, improvements in health and health equity the box on the right, are expected to improve the overall social context and social structure and lead to further health and health equity advancements. As you can see, the associations between social factors and health are quite complex. Multiple pieces of evidence over time and from varying contexts provided and continue to provide a base for understanding the social determinants of health. Next slide, please. As I already noted, the WHO framework makes an explicit reference to health inequities, a term we do not often hear in the United States. Although I must say I was on a webinar earlier today for the Population Association of America and some other affiliated organizations, and that's what they were using, health inequities. Our health agencies, health systems, and even much of the health research community keep focusing on disparities. This term doesn't have a uniform definition, but broadly means unequal distribution of disease and mortality across different groups based on SES, gender, race, ethnicity, and other social positions and identities. Eliminating disparities is a national objective for public health in the United States. There are social system and discipline-based variations in approaching health disparities. Healthcare and psychology approach disparities from the individual perspective, while public health, sociology, and epidemiology approach disparities from the social and population level perspectives. These different levels of emphasis result in different strategies to combat disparities that are implemented at in these different areas of society in terms of health. There are also regional and cultural variations in approaching health disparities. European countries focus on class and SES inequities, while the emphasis in the United States is on differences in health and healthcare, mainly based on race and ethnicity. So the term inequities and equity building are a little controversial here in the US context, but I think they're picking up and more people understand that to move forward, we have to move beyond the concept of describing disparities and defining them. So the next step is equity building and interventions. Next slide. So just to generally recap this whole idea about social determinants of health, here's the reminder from the global perspective, the quote, "Equity isn't just about lifting up the poorest or the bottom, but it's the entire spectrum of disadvantage." With the overview of the social determinants of health framework generally, let's turn to what we know about social determinants of health in epilepsy. I will review some of the key social factors, especially socioeconomic status and race, as well as mechanisms through which social determinants of health operate to influence epilepsy care and outcomes. I will first address research evidence that I compiled for a review article in 2014. Much of this information remains current, but I will also provide some more updated evidence for you. And please note that I'm just highlighting what's known and largely focusing on my own work to bring my own perspective into it. But it is really just scratching the surface of the field. There is so much more out there to what I'm presenting today. Next slide. Just to give you a glimpse of the literature during the period when I was doing the review. So for the 2014 article, I had searched for publications on social factors and disparities in epilepsy, and found a higher number of articles published in 2009 compared to each year after that through 2013. And among the scholarly journals, Epilepsy and Behavior led these publications. and the rest of articles were spread across various epilepsy, neurology, and other health and social science journals. And obviously, it would be very interesting to take another look and see where we are today with these publications. Next slide. So in terms of socioeconomic status, research has shown that socioeconomic deprivation likely increases the occurrence of epilepsy, and that people living with epilepsy have lower education, household income, employment opportunities, and health status compared with people without epilepsy. However, research findings are not consistent across studies, and most studies are limited in the ability to unpack the complexity of relationships among social factors in epilepsy. So what we see in the literature is that associations between social determinants of health and epilepsy care and epilepsy outcomes vary across health measures, outcomes, and control factors that are used in studies. So we may see different associations, for example, when examining the prevalence of epilepsy versus examining medication adherence or non-adherence, or when looking at access factors, for example, insurance, or psychosocial resources such as health literacy. So we have to take that into consideration that by looking at different things, we find a little bit different associations. However, generally speaking, we do know that socioeconomic factors affect people with epilepsy generally, and then their care and health outcomes specifically. Next slide. In national adult samples of people with epilepsy, current data show no race and nativity differences in visits to neurologists and use of anti-seizure medications. But African Americans are shown to have higher rates of acute care, deaths, and less advanced treatments, for example, epilepsy surgery. People with epilepsy of other minority backgrounds have also been indicated to experience barriers to care, epilepsy stigma, and potentially poorer outcomes. However, evidence on race and ethnicity in epilepsy is still limited. Especially little is known about the role of implicit racial bias in epilepsy care and its effect on outcomes, as well as how intersections of multiple marginalized or stigmatized statuses or identities, for example, intersections of minority background, poverty, and stigma of epilepsy, affect care, experiences, and outcomes among people with epilepsy. Next slide. Age is also a social determinant of health in epilepsy, as people with epilepsy in different age groups have special epilepsy-related needs and vulnerabilities beyond biological factors, but derived from the social standing and social and biological intersection. Childhood and old age are particularly vulnerable stages, and also disadvantages, for example, experiences with discrimination, can accumulate over the life course. So that's where age also comes in. So generally, age should be viewed as a social, not only biological factors in epilepsy. Next slide. Some gender differences in the use of care and outcomes have been reported among adults, but not among children with epilepsy. For example, women have been shown to have higher use of neurology care versus general practice services for epilepsy. Also, quality of life in epilepsy may vary based on gender. For example, women of childbearing age may have unique needs and vulnerabilities which may affect their quality of life. Next slide. Contextual conditions are coming to the forefront as we examine place-related quality of life and access to epilepsy care, which is limited in some areas and affects epilepsy outcomes. Some studies show, for example, that people with epilepsy assess their neighborhoods as less safe than people with epilepsy. Also, a new study by our group shows that people with epilepsy residing in regions outside the Northeast are less likely to visit a neurologist or epilepsy provider. And this association is strongest for people living in the South, which is becoming known as the epilepsy belt, with relatively more cases and more uncontrolled cases of epilepsy compared with other regions. In addition, there may be some urban-rural differences in epilepsy, but in terms of research evidence on this point, it's somewhat inconclusive, so we need further investigations. There are multi-level contextual factors in epilepsy, structural and cultural, that are not fully understood, though the high economic and human burden of epilepsy is known and has been quantified. And the overarching goal is to develop interventions at different social levels to help to reduce that toll of epilepsy. Health policy, health systems, and professional education must be addressed. Cultural interventions, such as increasing public awareness and stigma reduction, are also key. And on this point, I would like to note that stigma is now considered one of fundamental causes of health disparities, alongside of social class and racism. Next slide. There is significant complexity to social determinants of health in epilepsy, and evidence about these mechanisms through which social determinants of health operate to influence outcomes is limited. So one place to start is to recognize that based on the social determinants of health framework, multiple mechanisms exist, and follow this framework to build further evidence to guide future interventions to reduce disparities in epilepsy. Next slide. So this is a proposed social determinants of health epilepsy framework with specific items under the social context. On the left, for example, you see public policy there and culture. So under public policy, some of the things that are important to note are epilepsy care and treatment regulation, funding for research, education, and healthcare services, anti-discrimination laws, public education about epilepsy, and epilepsy advocacy. Under culture, we note social knowledge and beliefs about epilepsy and attitudes and behaviors toward people with epilepsy and their families, especially levels of stigma and discrimination. That's some area that we need to investigate and see whether the interventions that we have can reduce stigma, are actually reducing stigma and discrimination, for example. Then embedded in that social cultural context of epilepsy, the box on the left, is the social hierarchy or structure with individual social statuses or identities in the middle left box. These are positions with varying degrees of social power and resources, right? From socioeconomic position to minority, racial, ethnic status, to gender inequalities. Then there are material, behavioral, and psychosocial factors in the middle right box that are important to consider in epilepsy. And plus there is this circle with the social capital factors. For example, epilepsy social networks that are important in terms of both social capital is actually a very complex construct, but the idea is that it is the resources in the community and neighborhood and social networks that help health. And so individuals may draw on these resources. And the reason why there's this circle is that those resources are part class and group, demographic group based, but they also are very much connected with psychosocial factors, psychosocial resources, such as social support that can be drawn from social networks and from community structure in terms of social capital. Another important block of factors to consider, obviously, in epilepsy outcomes is epilepsy care. And please note, in this model, just as in the general social determinants of health model, that box isn't quite as big as everything else in the model. Don't you agree? And so there's this general idea out there that about 80% of variation in health can be explained by social and behavioral factors, and then the rest of it by healthcare and some other factors. And so obviously healthcare, the healthcare system and healthcare services delivery, that's very, very much important and relevant in epilepsy as in any other conditions. But look at these all other factors, socioeconomic and political, contextual and social structure, and then behavioral and psychosocial. That actually accounts for more in the variation in the outcomes than healthcare itself. So again, looking at the whole model, there's a whole web of factors that are proposed to shape the items on the right. And some of the dimensions of the outcomes that we look at in epilepsy is epidemiology, so occurrence of epilepsy in a population. We look at epilepsy patient outcomes, and so direct disease outcomes, as well as patient-centered outcomes. So perceptions of patients with their life in epilepsy. And then obviously a big portion of the outcomes are disparities, because we know the disparities exist. So in order to design any interventions to draw on social determinants of health and their role in epilepsy, we need to assess disparities and any progress toward reducing and eliminating disparities. So the next step is actually trying to test parts of this model through empirical research, and there are many different parts of the model, right? So it's very difficult to do it in one study or even in several studies, but rather, taking it apart and looking more closely at the different boxes and how they are related. That really helps building evidence. So that's what me and my colleagues have been engaged in the last 10 or more years now. Obviously, I do not only focus on epilepsy, but also on other health issues, but this is one research program that I'm very passionate about. Next slide, please. So here's an example of our research study looking at what predicts visits to neurologists and use of anti-seizure medications among adults with epilepsy. So in that study with national data, we were able to show that lack of insurance and region, so where people live, I mentioned that before, outside of Northeast is a barrier for people to see a neurologist and then have better outcomes because of it. On the other hand, poverty was the key barrier to accessing anti-seizure medications. You can see here that by looking at different outcomes in epilepsy, we will find different social factors that operate here are important. And so we need to identify these factors specifically in relation to certain outcomes, right? Because those will be the points of intervention for different social systems and for the nation generally. Our team has also examined socioeconomic factors in patients with treatment-resistant epilepsy, so those with recurring seizures, uncontrolled seizures, the most vulnerable population within the general epilepsy population. So even though the majority of our sample was white and socioeconomically well situated, some patients struggled financially. For example, 23% had family incomes less than $40,000 a year. 18% experienced money troubles. 13% food scarcity. And 8% could not always afford medications. We also showed that overall health status of these patients were associated with higher age and lower income. in combination. The graph here shows the health ratings from poor or 0 to excellent or 4 for patients in lower and higher income categories. And as an example, we picked a 10-year-old patient, the gray bar, and a 40-year-old patient, the black bar, in these two income categories. So even though all lower income patients, the left bars, had lower health ratings than the higher income patients, the right bars, the younger patients in both groups had an advantage over the older patients. Next slide, please. We have also extended our examination of social factors in epilepsy from patients to caregivers, mostly families, but also outside of families, other caregivers, and described how affiliate stigma of epilepsy among caregivers contributes to the burden of caring for patients with recurring seizures. So that's an example of another kind of dimension of epilepsy, the family situation and how they're faring, caring for these patients. We also looked at other factors, social factors in epilepsy, like health literacy. This is really a psychosocial resource. And we found an association between health literacy of patients and their caregivers and quality of life of these patients with treatment-resistant epilepsy. So we have now a body of information, a body of knowledge from the specific population of people with treatment-resistant epilepsy, and we know that they are a very vulnerable group because physically their seizures are uncontrolled, and on the top of it, they struggle socially and psychologically as well. Next slide, please. So based on existing evidence about disparities in epilepsy, the Institute of Medicine published recommendations for action to reduce and eliminate disparities. These recommendations include surveillance of epilepsy, not only case-wise, but in terms of service use and cost, access and quality of care, risk factors, and patient-centered outcomes. Health policy and the public health system from national to local levels must be on board and do their part, for which public health funding is essential for both data collection and public health interventions, such as improving access to services and treatments. Healthcare organizations, healthcare delivery must do their best to evaluate, track, and improve quality and value of epilepsy care for all types of patients, but especially for racial ethnic minorities and socioeconomically disadvantaged groups. Epilepsy professional education needs to evolve as well to change culture, strengthen disciplinary expertise, and empower epilepsy organizations and centers of epilepsy care to act on disparities. Additional recommendations include improvements in quality of life and community resources for people with epilepsy, education of patients, families, and public education. In addition to the Institute of Medicine guidelines, the National Public Health Plan, Healthy People 2020, that specified a national objective to increase the proportion of people with uncontrolled seizures who see a neurologist at least once a year. So that's the standard of care in treatment-resistant epilepsy. The progress on this objective has by now been reported. So over a decade, from 2010 to 2020, 10% improvement on this measure has been achieved. But that, of course, gives us the leftover part. Still over a third of patients with uncontrolled seizures remain in the vacuum and do not have appropriate care and treatment to improve their seizure status. So that there's a long way to go to reduce that gap. So one way that further progress can be achieved is by various epilepsy stakeholders working together. And I think it's happening more and more. For example, our Alabama chapter of the Epilepsy Foundation is doing a great job, not only directly supporting our local epilepsy community, but by connecting with and engaging policy makers, healthcare providers, professional education, and researchers. So we're really coming recently, I have seen that coming together really nicely. And from my own perspective, I think academic institutions have especially a multidimensional role to play in all these areas, right? In education and research, practice, and community and public engagement. However, it's challenging for academic institutions because funding is scarce. And so we need more funding for all these areas. Without funding for each of these areas, progress is and will be slow. So here are a few takeaway points from this session. First, the social determinants of health are responsible for most variation in health status across populations, social groups. So they are responsible for the production of health inequities. The social determinants of health framework guides us in efforts to understand what social determinants of health are, how they impact health and healthcare, and how to develop and prioritize interventions. And this framework applies in epilepsy, and it must be understood in order to develop interventions at various social levels. But much work remains to be done on reaching these goals. And finally, like I mentioned just a few minutes ago, stakeholders in these efforts are multiple and include providers, patients and families, policymakers, public health officials, researchers, and community and advocacy organizations. Now, I've been thinking about how much we know about these partnerships, and it hasn't really been quantified in the literature. It would be very interesting to look at what these partnerships are, where they are successful, where there are still lessons learned to improve the effectiveness of these partnerships. So at this point, we know little about where we are working together and how much work remains to be done to reach full levels of engagement to really make a difference on disparities and on improving health status of people with epilepsy. There are multiple resources I used today. If you would like copies of any articles that I used from our own research or anything else, some other resources, I'll be happy to share them either through the Epilepsy Foundation or this network, or if you email me and would like something specific, I'll be happy to share. So please reach out if you.
Thank you both. We just want to share real quickly that there are a number of resources you can turn to after today's session to continue learning about epilepsy and social determinants of health. Resources for providers, patients, and links to these resources can be found on epilepsy.com and by calling our Epilepsy Foundation 24/7 helpline. This presentation and the resources you see on the slide will be available for viewing on epilepsy.com. We also will be sending it out in an email to everyone who registered, as well as a evaluation. And we really ask that you please complete that, as that provides helpful data for us as we continue to plan future webinars. And I just want to thank you, Dr. Manderscheid, for supporting and guiding this work in behavioral health and epilepsy, and for giving us the opportunity to be with you all today. And I'd also like to offer a special thanks to Dr. Schabowski for sharing her time and her incredible wealth of knowledge and experience with us this afternoon, and for her steadfast support of the Epilepsy Foundation and epilepsy community at large.